Good morning. We're going to make a start, if that's all right, so we can let you out for lunch on time. Welcome to Essity's workshop. My name's Josh. I work as one of the key account managers at Essity, covering the Southwest and the Midlands. And my colleague Rich Madison has joined us today, one of the strategic healthcare partners. We were going to have Sharon, one of our consultants, with us. Unfortunately, she's had to work clinically, but she's provided us with a pre-recorded video, giving us all the information that she wanted to share with us today. So today we're touching on the challenges of improving infection prevention and doing this in an acute setting, and hopefully providing you with how industry can support you in this and help get rid of some of these challenges, some of these barriers, so that we can improve infection prevention now. So a quick overview, we're going to have the pre-recorded video from Sharon Morad. She's going to be sharing some of the challenges she's faced over about a 4-year period in wanting to improve infection control. We're then going to be sharing how industry can actually support you in some of these challenges, as well as some of the Essity toolbox things that we can provide you with to help move these challenges out of your way and improve infection prevention together. We're then going to talk to you about some of the NICE guidance that was recently accredited to one of our products. And finally, you're going to hear from some researchers at the University of Birmingham who have performed a meta-analysis in order to look at dressing selection post-operatively and whether these dressings are effective at preventing surgical site infections in an acute setting.
So thank you very much, everybody. I just wanted to introduce Essity, because I'm not sure how many of you will actually have heard of the company. You will have heard of a lot of our brands. We're potentially the biggest company that you haven't heard of. So Essity is a global health and hygiene company, and we are responsible for brands such as Tenor, Talk and Hygiene, the paper tissues, but the area that myself and Josh work for is the medical solutions. And this is where we're really going to be focusing around the infection prevention and the NICE guidance products that we're going to be describing later on. So following this slide here, we're going to introduce Sharon on the pre-recording, and then that's going to be played in. Then we're going to have a little bit of a conversation around the systems thinking and how infection prevention can actually be at the heart of the new way of working in ICSs and how Essity can support with that. So if I flick onto that next slide now.
Hello, my name is Sharon Morad. I'm a consultant obstetrician and the clinical lead for delivery suite at Birmingham Women's Hospital. And I've been asked to talk about some of the challenges that I've gone through in our journey of trying to improve infection prevention in an acute hospital trust. So some of the things that I'll start with is the journey that I've gone through in order to improve infection control, and also to look at ways that I was supported by industry and the way that the NICE guidance can also help to improve infection prevention in maternity care. So my journey actually begins quite a long time ago now. I started my first consultant post in September 2017, and within a couple of weeks, I was first contacted by an Essity account manager who told me about this new dressing that they were advocating, which could reduce surgical site infection following cesarean section. And I used some of my first study leaves to attend the Essity maternity conference in October. Came back very enthusiastic. This dressing seemed to fit lots of things that I was interested in. It would be a benefit to women by reducing their surgical site infection. Also would not increase resistance to antibiotics or to other antimicrobials. And I very naively thought that all I had to do was come back to my trust and inform the powers that be of this amazing new technology, and they would be delighted to introduce it in the benefit of our women. Unfortunately, it wasn't quite so straightforward. So the barriers that I felt at my first trust was, first of all, trying to persuade people that there was a problem. We had no baseline surgical site infection data, and there were a lot of people who said, but the national data suggests that, SSIs are only about 4%. This isn't a particular problem. Why should we spend money for something that isn't really an issue? And then I spoke to some microbiologists who said that their feeling was that actually this was a much bigger problem than any of us were aware of, gave some internal studies that they had done suggesting that our SSI rate was probably at least 10%, maybe higher than that. But it was hard to get anyone to take me very seriously that this was something we needed to change. I also found myself enmeshed in a whole series of internal politics. It was unclear exactly whose job it was to change dressings. Was it infection control? Was it tissue viability? did maternity have to follow exactly the same practices as the rest of the surgical departments? And because of that, I kept on getting moved from person to person, never really figuring out who it was that was responsible. There was so much red tape that in the end, the trial that we had intended to start got abandoned by the clinical leadership. It all ultimately came down to money. It was going to cost a little bit more. It was unclear how much we as a trust were going to benefit. And so after about 18 months, it kind of withered on the vine and I didn't get any further. In 2019, I was facing a new beginning. I had moved trusts at this point and was being put into a position where I was going to have more direct leadership on Delivery Suite. And most fortunately of all, I came to the trust shortly after we received the results back from our participation in the clinical trial. And that trial wasn't included as one of its measures surgical site infection data following cesarean section, and the trust was astounded to hear that our SSI rate was 22%. So because of that, there was already this sense of urgency that something needed to be done about SSIs, and the person I replaced had already begun a project saying we need to start doing something, and hers was focused mostly at changing the timing of prophylactic antibiotic administration at the time of elective cesarean section. So one of the first things I did was suggest the leucobed storeback dressings, and the response I got was very different. I was told, in principle, this sounds like a good thing, but what I was given was more direction, which said I needed to demonstrate that the trust couldn't get our SSI rates down sufficiently with measures that didn't incur cost before they would be willing to then look at a measure that was going to be a little bit more expensive. So the very first thing I did was benchmark what we were currently doing against the NICE SSI quality improvement standards, and I found several areas where our work was not quite adequate. And thus RIO, Reducing Infections in Obstetrics, was born. This was a rapid quality improvement project which began in September 2019, and it included five measures which were not particularly expensive and were moving us in line with NICE guidance. So we introduced fenestrated drapes. We got them to prep the abdomen correctly and leave the prep to dry instead of wiping it off. We introduced vaginal preparation preoperatively for all cesarean sections, Instilogel for catheterization, and the trichlorosan-coated sutures. So this group of measures was introduced all at the same time, and we, after 3 months of implementation, we then went on and we did an SSI audit for the next 3 months with a team of 9 junior doctors who followed up all the women that had cesarean sections in that time. And we did find that there was some improvement. Our SSI rate reduced from about 22% to 18%. But it was easy enough with those data, particularly when combined with our process markers showing that we actually were doing what we said we were going to do, that we were able to demonstrate that we needed to do something more to get our SSI rates down to an acceptable level. Unfortunately, that was then bringing us directly into the period of COVID, and everything became much slower and kind of reduced the frequency again. So in May 2020, I got agreement in principle from our ops manager to switch to the storeback dressings. And unfortunately, we then went through a period of about another 18 months where we had multiple changes in ops managers due to illness and promotions and various other things. And so it was very difficult to progress with the business case. And by autumn of 2021, I was getting extremely frustrated because, I felt like I had, unlike my previous trust, everyone agreed with me that this was the right thing to do. I just couldn't get anyone to actually make it happen. So I escalated this to the medical director as a patient safety issue, and was met with a response of a great surprise at something that was so simple and obviously of such benefit to the women that we look after hadn't been introduced yet. So within about 4 months of that escalation, we had money that was available to do a long-term trial, and then in March 2022, the dressings finally were in use. This was after a period of very intense training by the Essity team, and I'm very pleased to say that after having been in use now for almost 2 months, it is now standard practice. People understand how they're supposed to be used, and they understand why they are of benefit to the women that we're looking after. So when I reflect back on the years that it took me to get these dressings introduced for the first time, I can think of several things that were particularly challenging. So the main thing is, coming in as a new consultant, understanding the system. What I really needed was an ops manager that was on side with me from the very beginning, because I needed to know what forms needed to be completed and how to write a business case. So the Essity account team were very helpful with giving, generic and national information. But what I needed was local information. What were the particular facts that were important to this particular trust? I needed to know who completed these business cases and also who reviewed them. And it took me a long time to understand who the most important people were to get on side. And in the first trust, where there was a lot of politics involved, that was incredibly challenging. The other thing that was difficult that I hadn't expected was the whole question of who benefits, because I just thought what matters is that it benefits the women. And I think ultimately, I do believe that, the managers and everyone that do think that, but they do have to pay attention to the finances. And when I would come along with the figures, from the NICE technology assessment, for example, saying, look at how much money these dressings could save by reducing SSI rates, the response I got at that time was, these savings may accrue to the system as a whole, but how much that money is going to be saved by our trust? And of course, I had no real way of knowing how to break that down. My understanding is that as we move to integrated care systems, hopefully this particular conflict between two different NHS organizations will be less of an issue, and we realize that financial benefits to the system will benefit everyone. The other thing that was quite difficult was the whole question of how to prove efficacy when there is no SSI surveillance. And we all recognize that certain interventions may show a lot of improvement when we do it in a clinical trial, but they don't necessarily show the same level of improvement in real life. So the data from Wales was very beneficial in showing a big real life example of this providing benefit. But I also needed to come up with our own metrics for how we were going to demonstrate that it was of benefit to our women. We don't have the resource to do actually complete thorough SSI when having cesarean sections. So we've now agreed a range of proxy measures for SSI surveillance. So we're going to be looking at trust antibiotic use after cesarean section, particularly women that are sent home with antibiotics. We're going to be looking at wound swabs, not so much as every woman that gets swabbed will automatically have an SSI, but we will know that there was something about the wound that bothered the clinician enough to want to swab it, and we would hope that we would see fewer concerns and therefore fewer swabs being required. We'll look at length of stay after cesarean section, and also we'll look at the number of women that come back to triage after cesarean section with concerns about their wound. We have within our electronic patient record an SSI documentation page, and part of what we have requested the midwives to do is to complete a description of the wound on day 5 when they remove the dressing. And then after that, we're aiming to do a telephone follow-up of women at day 30, basically to find out if women were started on antibiotics after their day 5 midwifery review. So hopefully that will give us short-term follow-up information as well as longer-term follow-up information. We appreciate none of that is perfect, but it seems to be possibly more achievable than complete SSI surveillance given the financial climate that we have. So this is still a journey. We have begun, and I'm really pleased with the progress that we've made. I'm really hopeful that these dressings are going to make a difference to the women, and it would also be nice if we could demonstrate financial benefit for the system as well. But there are probably more things that we're going to need to do, and having these proxy measures for surveillance will help point us in the right direction. So I would like to say thanks to the Essity team, who have been incredibly encouraging over the last few years. And at times when I was tempted to just, give up because it was too hard, they would offer new information or the latest article that had been written, and that helped encourage me to keep going. So thank you all very much.
So that was obviously very interesting from Sharon, and it's a shame that she can't be here, but as Josh mentioned earlier, she's actually been brought into clinical responsibilities today, so that's why we got the pre-recorded video. So what I'm going to be talking about now is really to touch on a few points that Sharon actually mentioned around the hope of infection prevention running through the sort of that systems thinking, and also to touch on some quality improvement sort of examples and work that we can do to support your trusts if that was something that would be of interest for you to be able to sort of put that infection prevention and SSI surveillance higher up on the agenda. So we're just going to run through a few slides now. So this might be telling you things that you've already seen, you've heard, but I do think it's important to sort of run through this again. So the ICS is really looking at 4 fundamental areas: improving population health and healthcare, tackling unequal outcomes and access, enhancing productivity and value for money, and helping the NHS to support the broader social and economic development. And I think we can all agree in this room that good infection prevention that's linked up through different services can really help achieve all of these sort of goals that the ICS have tested. And one of the things that Sharon touched upon was the fact that some of the benefits to improving the care within the acute side is actually found within the community setting or into the primary care. So there is an element of hope. There's still a lot of challenges to go through with this, but embedding this thinking into everything that we do around this wider impact at the system, I believe can really help promote the infection prevention side. And SSIs are one of the biggest things that impact on the community that sometimes would start in the hospital. So this is really where, from an ICS point of view, if we can run the infection prevention agenda, the SSI prevention, through that whole system, we can benefit through stronger partnerships. Provider organisations are being asked to step forward. So from an infection prevention, a surgical point of view, is this something from a provider collaboration that we could start to build up these links into the community providers that you're in this collaboration with, because you will all be hopefully pulling in the same direction of trying to improve them outcomes. Developing strategic commissioning through focus on outcomes. I mean, this is something that we've always should have been doing, but at the same time, now if we're looking at that overall budget, that might really help the actual, well, spending more in hospital A will actually impact in B, C and D within the community and within the different providers. And the use of digital and data, and this is something that Sharon touched upon that is so difficult, and it's very, very hard sometimes to be able to get that data. One of the things that Essity will do with working in partnership with all of our customers is try to get the best possible ways of using digital, using data to be able to support your trusts. Things like QR codes. I know this sounds really simple, but making a Microsoft Forms where you can have people feed back whether they've had to have a GP's visit, if they've had antibiotics prescribed following the discharge, that will be a really strong way of us actually building up an idea of what's happening in the community. And I've asked the question, are we ready for systems thinking? And my background is I worked in the NHS for 7 or 8 years before I started here. I worked in medicines management, safety, quality and risk. And I think we've all been ready for systems thinking. It's just we need the people at the very top to really adopt that. We've all wanted to be able to impact on one another and be positive, but when we have had such siloed budgets, it really can affect it. So now, what we are trying to do with our customers is really drive this SSI prevention up that ICS ladder of where it is important, because just from following C-sections, that can have impacts on the mother, the child, and it's a ripple effect that then affects that whole system. So this is why we're really keen to have the ability to raise this agenda of SSI prevention following surgery. And this is really the 3 big breakdowns. So we've got neighbourhoods, places and systems. I'm not going to read it in, but the neighbourhood is where your PCNs sit, so your primary care networks. Everybody on this list here has an impact on prescribing of antibiotics, the use of antimicrobials, and also all of these will be impacted by surgical site infections, etc. So it's how we can link these together so everybody can see the benefit of, as Sharon said, using something slightly more expensive, but it's not more expensive. Once you actually look at the impact that that product has, it becomes incredibly cost negative. So it's about us actually being able to prove it across these different areas and have that joint understanding. And this is, I looked a lot better when I actually put this together in the first place, but this is what I used to come across. We would all be wanting to do the right thing within the NHS, but you would have the community providers sat with a different budget to the acute trusts. You'd have commissioners that had different agendas. What we need to be looking at is putting the patient at the centre of everything that we do. And if we put that patient at the centre and work backwards from that, everybody can help one another. It will help with the getting it right first time. It will help the workforce actually deliver value, and not just value in a cheap product, value in health outcomes and that wider impact on the budget. The self-care in this one might be a bit, but from a new mother, self-care is their mental health. This is them actually feeling happy in the ability to be able to look after the child. Having an SSI following a C-section in the first 5 days that requires antibiotics, that will impact the bonding. So that self-care, it's not meaning delivering the C-section themselves, but actually caring for themselves following that very traumatic, stressful event. SSI should be something that should never really come into that thought process if we have the ability to reduce it. And primary and community care, if we can link it all up, will help take the strain off the acute side. So it's really about getting this overall vision of how we can do it. And I'm not going to talk quality improvement in too much detail because you will all know probably more than I ever will with it. But we have really adopted this plan when we're looking at using Leaflets Swabs within trusts. As Sharon mentioned, she really struggled to get this on people's agenda. She created a quality improvement project which helped drive that up to the top. And it gives us the ability to follow the PDSA. So plan the objectives, do and collect the information, study and reflect, and act on what the actual impacts are. And one of the things that we can do at Essity is we can support you in the creation of quality improvement documents. So we know how busy you all are. You have 30 jobs going on. If you are wanting to look at implementing something like Leaflets Swabs following C-section and vascular or any surgery, we can support you with these quality improvement documents to help take the strain off you also trying to get your day job and get something put onto that agenda. And this one here is one that I would really like to point out about who are the stakeholders, because as Sharon said, that is essential to actually being able to get the right people around the table. And it's something that on a later slide, Josh will touch on about the people that we would really look to bring into this journey from the start to be able to deliver that through. So that was the key, sorry, one more slide. The key takeaways for that is the fact that we are struggling to get through the backlog of elective surgery. We know that it is an absolute focus. And really avoiding any errors or avoiding any readmissions is absolutely crucial, more now than ever. So if we can embed a patient-first mentality across healthcare, it will support the outcomes that we get. Our portfolio can help reduce hospital admissions and readmissions and reduce the total cost of delivering care. The quality improvements can make a driving force for the acute trusts. So get that on the agenda, and then everybody is seeing the improvements that makes, which then raises the profile of it. Systems thinking can help support the impact. So if we have one area that is going to benefit, we can have them discussions now because there is the system. And data is key. And we can support with data analysis. We do have an audit team that can give advice and support moving forward. So if that is something that we need to discuss, we can obviously factor that in along the way. And now I'll hand it over to Josh.
Perfect, thank you. So, partnering with industry, how can we help get rid of some of these challenges from your everyday work life? We've listened to Sharon go through quite a lot of these challenges, and we've invested heavily in tools to help you move these out of your way and improve infection prevention. Hospital episode statistics. These are done across all of acute trusts. What we've invested in is a dashboard that allows us to look not only on a national, but actually on a regional and a really local level at what that data is actually telling us. We can see here is a snapshot of the national picture, but we can put this down to local level. We can pick out one trust, look at the hospital readmissions data for patients who have been coded as infection following C-section or infection following vascular surgery. And then we can use this local data, as Sharon said, to help put this on the right people's agenda so they understand that there is an issue there. Anybody that's interested in understanding what your local picture looks like, come and see us on the stand later, come and see myself, and we can look through this hospital episode statistics in the dashboard and understand what this really means to you and your trust. Path. So it's not just about the data to help you, but we're there the whole journey. We don't leave the product and then we're gone. Luckily, we've seen a couple of familiar faces on this conference, a couple from Anar and Bevan, who were instrumental in getting Lucamed Sorbact off the ground at the start of when we launched the product. So there was a couple of maternity nurses, I'm not sure if they're in here, but they've been in the conference yesterday, who we worked with to show the impact that Lucamed Sorbact has had. We then published the paper, and that was a massive driving force towards us achieving the NICE Medical Technologies guidance. And on the other side of that, we've seen a few from the Liverpool Women's Hospital, who are just about to undergo that implementation period, where we've supported up to this point, and we're now looking to implement the product into their everyday practice. But Path features all the way along that. Path is our new educational platform, where we can offer education via face-to-face, the traditional way before COVID, or now virtually, or via e-learning. And we'll be there to ensure that the staff have the right education to identify what a surgical site infection is. What's actually just normal wound healing. So we're actually getting the right data through, and all the staff feel empowered to make the decisions in their everyday practice. We're here as a team. We have huge resource in terms of people. Account managers and clinical consultants, they're there to support with product training and also that CPD accredited education. And it's all free of charge for people to access and use. Strategic health partners like Richard and key account managers like myself, we're here to support in the background, but we can develop clinical pathways for you so that we know that patients are moving through the system efficiently and the right patients getting the right product at the right time. We can also support with audit advice and support to demonstrate the impact. So once we've put Lucamed Sorbact into place, we can measure a baseline and we can measure the end results. So we can go back to those people holding the purse strings and saying, look what we've achieved here. Let's look at other specialties to implement this product in as well. And there's a huge amount of support from NICE with the NICE guidance that I'll cover in a moment. And finally, support with the seamless transition of care. We've talked about going from an acute setting into the community. We need to bridge that gap. We've worked on patient discharge leaflets, so empowering the patient. We've worked on wristbands so that community nurses and community midwives know what patients have what dressing on, and everything in between. Some examples of the support that we can offer as a company. You can see the bracelets on the left that identify patients using the dressing. On the right here, it's blurry, but that is the front page of the business case that we helped produce for Birmingham Women's that's ultimately seen them now start using the dressing. An example of pathways, and we've got examples of these pathways on the stand where we can identify high or low risk patients and what dressings they should be going into. And we can work with these. It's your clinical input and the trust's clinical input we need to design them, but we can facilitate that pathway being put together. Examples of patient information leaflets, again, empowering the patient and developing self-care attitude. The front page of the report published from Anar and Bevan, which I mentioned briefly earlier, they saw about £160,000 saving from implementing this into the trust. The investment was around £20,000 in terms of the dressing and £160,000 saving in one department, in one hospital in Wales. If we multiply that out widely, we can make huge savings for the NHS at a time of financial struggle. More patient information leaflets, working with best practice statements. Again, other examples of pathways, working with other companies. We know that Lucamed Sorbact won't go on every single patient that goes through a hospital, and we're happy to work to identify those patients it is required for. And again, the educational support that we can offer in Path. Partnering with the NHS. As I mentioned, we had some NICE Medical Technologies guidance issued February last year. They are saying that Lucamed Sorbact should be used for all patients undergoing C-section and vascular surgery. At the moment, it's those areas because we have our clinical body of evidence in those areas. But the experts are confident that it could be used more widely than that. We are working to develop it in colorectal, breast surgery, all of these. But at the moment, the NICE guidance is there to back you up for those specific areas. And as part of NICE, there's a huge number of tools that they offer that can support us in the implementation. Tools and resources, impact templates so we can measure the impact that it's had. Assumption templates to demonstrate the actual cost savings that you could achieve, and we can use that HES data mentioned earlier to show you what that could look like for your trust. It's underwritten by experts in their field that are looking at clinical evidence day to day. And it is indicated for additional surgeries. And these clinical experts are very broadly hopeful that it will work in other surgeries the same way it's worked in the 2 that we've demonstrated so far. These are some researchers from the University of Birmingham. Following the release of the NICE guidance, they wanted to have a look at all the different types of dressing and whether any of them are having an effect. The results have come out from that meta-analysis, and they're going to summarise those for you. But pleased to say that the feedback for Lucamed Sorbac comparative to the other dressings available was really, really positive and supported that NICE guidance.
Welcome to our presentation on Lucamed Sorbac dressings by Essity. My name is Smodini Wijitunga, and together with my colleague Ruby Hill, we will be presenting our findings from our systematic review and meta-analysis, evaluating the effectiveness of advanced dressings in surgical site prevention post-caesarean section. Secondary outcomes included endometritis, rehospitalization, length of hospital stay, and wound dehiscence. This review was published in the European Journal of Obstetrics and Gynecology and Reproductive Biology in November 2021.
So caesarean section is currently the most commonly performed surgery worldwide and in the UK. However, with UK rates increasing from 19.7% in 2000 to 29% in 2021, they currently surpass the World Health Organization's ideal range of 10 to 15%, sparking concern over the accompanying rise in infectious complications after caesarean section. Infectious complications, such as surgical site infection, are estimated to affect between 9 to 11% of caesarean sections in the UK alone. So surgical site infection, also known as SSI, poses a significant impact on both maternal and neonatal well-being. In addition to the personal cost, the economic burden on healthcare is such that in England, it is estimated that 5 million per annum has been spent by the NHS on the treatment of SSI post-caesarean section. As the occurrence of SSI could be avoided in 55% of all patients, it is imperative to focus research efforts on preventative measures.
According to the Oxford Centre of Evidence-Based Medicine, a systematic review of randomised controlled trials, or RCTs, is the strongest form of evidence. We therefore chose this study design. We also included a meta-analysis to statistically combine the results into a more interpretable and precise estimate. The main stages for our project included registering our study protocol with Prospero, conducting a literature search of 4 databases, study selection, data extraction, data analysis, and quality assessment of included studies. For data analysis, we used the software StatsDirect. Relative risks were calculated for each outcome in each study. StatsDirect then produced a forest plot to summarize the data, and we used a cutoff p-value of 0.05 to indicate a significant result. For quality assessment, we used the Cochrane Risk of Bias Assessment tool, which assessed bias in 7 domains to give an overall risk of bias for each study. Each stage was peer-reviewed, and any disagreements were taken to a third reviewer.
6 randomised controlled trials, or RCTs, were eligible for inclusion in the systematic review, evaluating a total of 2,295 women, 1,146 women with an advanced dressing, and 1,149 with a simple, non-impregnated dressing, such as gauze. These RCTs were conducted in high-income countries in hospital units. The studies eligible for inclusion included 1 study assessing the efficacy of copper-impregnated dressings, 2 studies assessing dialkyl carbamyl chloride, DAC, impregnated dressings, 2 assessing silver-impregnated dressings, and 1 assessing chlorhexidine-impregnated polyurethane dressings.
So what were the key results from our review? Firstly, DAC dressings were the only type of advanced dressing to significantly reduce the incidence of surgical site infection post-caesarean section. Additionally, length of hospital stay was significantly decreased with DAC dressings. By contrast, silver-impregnated dressings, a more expensive material, showed no significant difference in incidence of SSI and strikingly significantly increased the risk of endometritis. One of the RCTs, including in our meta-analysis, stated that despite DAC dressings being more expensive compared to simple dressings, The reduction in SSI risk and subsequent need for treatment saved approximately £119 per patient. Furthermore, at the time of publication, there had been no reported side effects of DAC dressings, most likely due to the compound remaining in the dressing rather than being released and absorbed into the wound. Whilst undertaking this research, new NICE guidance was published in February 2021, recommending the use of Leukomed Sorbact in caesarean section and vascular surgeries. By cost modelling, NICE had estimated a total saving of £5.3 million per year by adopting this DAC dressing, due to fewer people needing to stay in hospital for treatment of surgical site infection. Despite both RCTs investigating DAC dressings showing a high risk of bias, our results effectively confirmed the NICE recommendations, providing firm support for its use.
Dialkyl carbonyl chloride, DAC dressing, is a hydrophobic substance derived from fatty acids that is embedded into dressings to perform an antimicrobial action, but not in the traditional sense, as this substance does not initiate a direct biocidal effect. As many microorganisms are also hydrophobic, supplied with the moist environment from this occlusive dressing, they bind irreversibly to the DAC coating and are subsequently removed from the wound prior to their toxin release. This reduces contamination and colonization of the wound. These dressings are effective against a range of common bacteria causing SSI, such as Staphylococcus aureus, MRSA, and E. coli. They are also designed to provide maximal comfort to the patient, such as being highly breathable, easy to apply, sterile, and waterproof, providing a cushioning effect. So here are some of the references that we used in the creation of this presentation. We'd also like to make it clear that this research was carried completely independently from any company related to the inventions in the systematic review, interventions used in the systematic review. And thank you very much. Any questions, there will be a Q&A session at the end of this presentation.
So, Leukomed Sorbact, as she mentioned, is one of the DAC-coated dressing. It's the only one available on the market. If you have any more questions on the exact dressing details, please come and visit us on the Essity stand. I believe it's number 52, but I'm sure someone will shout if I'm wrong. Come and have a conversation with us and talk about how we can come and discuss this further, face-to-face or virtually over Teams in the next few weeks. Next steps, we understand that engagement is key, and you guys as infection control, microbiologists, and everything in between are top of our list of people that we need to be approaching and discussing this with. A collaborative approach is needed. We need to be discussing this with procurement, clinical governance, the surgical teams, the community staff, but also infection prevention and control. And that collaborative approach is what allows us to move this forward more quickly.